So I want to echo a few of the comments that were just made. And how do I blow this up? This is the new version. There we go. I just want to echo a couple of the comments that right now I really think we've entered the golden age of melanoma therapeutics. A few years ago, we could never imagine that in a single calendar year we would have 3 drugs approved by the FDA, where there hadn't been a drug approved in 13 years. And just to kind of put things in a little bit of a historical perspective, I don't think that all of the animal models and the war on cancer that was started in the 70s could have ever predicted the clinical results we're seeing in right now. And no way of modeling this. It's really just been the clinical observations and the clinical sciences that have helped push things forward. And the field is moving so fast that the number of opportunities and drugs and trials out there is somewhat overwhelming to the field, but is just, I think, so refreshing for what this offers for patients now and in the very near future. So I'm going to my duty in the next few minutes is to discuss with you the broad strokes of where immunotherapy is for melanoma, and particularly with the focus on ipilimumab, and I may be calling it IPI for short because it's just too much of a tongue twister after you say it 50 times in 30 minutes. But how this is very, I think, important paradigm shift in the way we think about treatment of melanoma and cancer in general, but it's just the beginning. So I don't want to get too technical, but I'm going to, for those of you who are not card-carrying immunologists, let me kind of walk you through a little bit of this just to kind of give you a sense of how this works, and then we'll kind of summarize the key features of this. So this is the basic interaction in the immune system, and this is the antigen-presenting cell, which can be a B cell or another cell called a dendritic cell. And this is fundamental for all parts of the immune system. For example, if you get the flu and a flu virus, how do you fight the flu? How does a body fight cancer? It's the same principles. And what this cell does, it takes proteins and chops them up into little bits and presents part of the protein on the surface of the cell onto a molecule called the MHC, or major histocompatibility complex. And it basically presents this protein to the powerhouse of the immune system, the T cell. And it does this through this called the T cell receptor. And what it basically does is it says to the T cell, go out and find anything that has this part of the protein on it and kill it. Okay, so that's what the job is. That's the fundamental thing. In order for this to occur, though, a couple other molecules have to come together and signal and find each other. And on the APC side, the antigen-presenting cell side, it's a molecule called B7. And on the T cell side, it's a molecule called CD28. And when those come together, along with kind of identifying the target of where it's supposed to go kill, the T cell goes out, starts dividing, starts making cytokines such as IL-2. It becomes potent. It becomes the ability to finally go out and do what it was intended to, find a protein and kill that cell that has a protein, whether it be a flu virus protein or an abnormal protein that's found in a cancer cell. Now, Mother Nature, in her wisdom, has it that you can't let anything just go untethered. If you just let someone who got the flu, the immune system, to continue on unhindered, you would start causing the immune system to cross-react to lots of different things like normal parts of the body and cause autoimmunity. So Mother Nature, in her wisdom, has this, when this happens, has this molecule called CTLA4, cytotoxic T lymphocyte antigen 4, comes on the surface. And this has a higher binding affinity. It's going to bind much tighter to B7. And when this happens, what the signal does is it shuts it down. It says, okay, time to go to sleep. So that you get the flu, you feel like you have a fevers for a while, you get muscle aches and joint aches for 3 to 5 days. CTLA4 comes out, the immune system kind of says, okay, time to shut down, and you make cells that kind of are memory cells. So next time someone exposes you to that flu virus, your cells come right back, fight it, and you may not get any symptoms anymore. What we're trying to do here is to fight cancer, block that interaction for CTLA4. So this is an antibody that blocks CTLA4 and thus really potentiates the T cell, pushes things towards the positive while essentially taking the brakes off, the natural brake to the immune system. And this is a kind of a famous cartoon in our community now that was originally developed by Jed Walchuk at Memorial Sloan Kettering. The way to think about this, because we just happen to be a couple guys sitting around thinking about this slide, is like a car. and that when the T cell receptor and the antigen kind of comes together and presents a protein, you're starting the engine to the car. And when the other molecules come together, you're kind of pushing down the accelerator to get the T cell to divide and make IL-2 and do all that kind of stuff. And what CTLA-4 does, it puts the brakes on the immune system. And maybe other things could help be the steering wheel and gear things towards fighting cancer, like a vaccine or something like that, which would help you drive it. But essentially what we're doing here is we're taking the brakes off, one of the natural brakes of the immune system. So there have been fully human monoclonal antibodies that have been developed that essentially take the brakes off the immune system in this way. And it was important because this all came from a key observation from Jim Ellis and colleagues, that if you've made an antibody in mice against CTLA-4 and you added a vaccine, that there was synergy. These two worked better together than they did separately. But it was associated with some toxicity. About half the mice lost pigment in their fur. They were black mice, and they became partly white, kind of what would be similar to clinically in patients having vitiligo. So we knew that you could take and cross-react to normal parts of the body. We also know that CTLA-4 was key in immune memory, so that if you block CTLA-4, any cells that were primed to fight against a certain protein would get activated very quickly. And so what we did at Dana-Farber is we took some patients who got a whole cell vaccine that's called GVAX, where the patient's tumor cells are taken out of their body surgically. They're brought to a clinical grade facility. The GM-CSF gene is put into them, and what that is it makes a protein like IL-2 and such to kind of boost the immune system. The cells are irradiated so they can't divide, and then the patients come in the clinic and they get a vaccine as a shot in the arm or the leg. And after they got that vaccine, we gave them the CTLA-4 blocking antibody, with the assumption that if we can prime the immune system, if we can educate the immune system as to what to fight against, and then come back and take the brakes off the immune system with IPI, then maybe we can make things better. So we treated 14 patients with GVAX and 4 patients that had gotten other types of vaccine therapies. And the dose that we gave is a little bit different than what's approved by the FDA. It is 3 mg per kg, but instead of every 3 weeks times 4, we gave a single dose every 2 to 3 months. And we did so because we were kind of concerned about the possible toxicities of giving things together. And as opposed to some of the side effects that we're familiar with CTLA-4 blockade, there were no grade 3 or 4, no high significant side effects, but some mild rash and some people who felt a little bit of muscle aches or joint aches. And out of those patients, a number of patients had, this is early on in the development of IPI. Out of 14 patients, we had 3 partial responses, and these numbers haven't been updated very recently, but are clearly ongoing. We had 1 patient who had a kind of stable disease and got 1 dose of dacarbazine chemotherapy and had a complete response lasting 3.5 years. And a number of patients who didn't have a formal partial response, but had stable disease were ongoing. And a number of these patients, fortunately, I still see in the clinic. The 4 patients who received other types of vaccines, unfortunately, did not do well. And this is a kind of a picture of one of the patients that a picture's worth 1,000 words. That's going to, I think, give you an important principle for immune therapy that's very different than what we see with target therapies or traditional chemotherapies that we think are effective. So here's a patient's lung mass, and there's also a melanoma that's surrounding her left lung here. After the first treatment, you can see this lung mass has increased in size while some of this has decreased. But this would be considered progression of disease by any of the standard response criteria that we use as medical oncologists that we all learned as medical oncology fellows. But with continued observation and treatment, this begins to resolve. And she continued to get treated until about 18 months ago, where she was flying from Venezuela to see us and just said, this is a long trip, what do we do? IPI is not commercially available, if I needed it, it's always there. And she has had very little symptoms, and this is about half the size. She hasn't all gone away. We don't know what's really existing, whether there's any scar tissue there or not, but she's done very well. The point is that sometimes things by a CAT scan with this kind of drug can look slightly worse before they get better. And this is a phenomenon that we have seen is kind of important to recognize clinically. This is another patient who came up from South Carolina to see me. Here's his lung mass here on the right, increased in size, and it finally decreased in size. And about 8 months later, the patient went to complete response, has remained in complete response since then. So clinically meaningful responses are possible without so-called autoimmunity. And just to kind of focus a little bit more on these kind of novel patterns of activity, So like I had said, it's important to recognize how this drug works. By taking the brakes off the immune system, we see from post-treatment biopsies that many of the sites of tumor can be inflamed with immune cell infiltrating, with swelling, just like if you got a cold and you had your sinuses would get all swollen up. I mean, an effective immune response can sometimes cause that swelling and edema, and that when you actually look under the microscope, you can see that a lot of the tumor is replaced by immune cells. So I'm going to show you just a couple of figures to walk you through this. 0 is the amount of tumor that a patient had at the start of treatment. So anything that goes up means that the amount of size measurements are going up. Anything that goes down shows that things are shrinking. And for someone who here, and this is time going kind of on the right here on the x-axis. So as a patient gets treated, you can see that here are the triangles showing when they got IPI. You can see that things go down and stay down. So that's something, clearly the patient had a benefit. That's kind of a no-brainer. This is much more complicated, so just bear with me to walk through with this. So the green is the amount of tumor the patient started with the treatment. And then the patient over treatment developed new sites of disease that's in red. So when you add it up, things get worse. And any new sites of disease, by any standard criteria, would be considered progression, and patient would come off a trial, and kind of the standard would be, gee, that patient's not receiving benefit, and move on. But with continued treatment, both the pre-existing disease as well as these new sites shrink until the patient actually has a response where the amount of tumor goes down. So things can actually not only get larger before they get smaller, but you can actually have new sites of disease that then respond. Now, not everyone has this pattern. I mean, there are clearly some patients who unfortunately don't benefit from it. But this all usually happens within the first couple months. And it really is intriguing and something to keep in mind, because we're dealing with a drug that has a very different mechanism than any other drug we had before this. And this is a patient who clearly looked like they were getting much worse, with almost doubling of her tumor volume, and then eventually begins to almost have a complete response. And you look at the number of days here. We're talking about things that are going out, half a year towards a year of therapy. So one of the key points here is that a drug like IPI takes time. And then I also will kind of advocate that for patients whose disease remains, quote, stable, end quote, for extended periods of time, that's a very important endpoint. We don't know what's really happening at the sites of tumors without a biopsy to say whether there's a battle going on between the tumor and the immune system and who's winning here in terms of what percentage of immune cells are there versus what percentage of alive cancer cells are there. But someone here who has disease that really hasn't changed within a range of tumor burden for a year is clearly getting a benefit to treatment, and this is a very worthy goal to achieve. And patients can be like this for a long period of time with a drug like IPI. So this is another example of a patient who, in the field, we kind of call skin man. This is a patient who has disease around here in the skin that looks like it gets worse after the first few treatments with IPI, and then begins to get better and then goes away. And pictorially here shows the patient actually gets worse by radiographically before it has a complete response that's durable for years. Again, another fairly dramatic example of how the activity of this drug is very different. So as a community, we developed what's called immune-related response criteria. And admittedly, this is version 1.0. It's not perfect. It's a first attempt, and it means for us as oncologists, as us who describe these phenomenon, who we all have seen that, to try to put together some sort of rigor, some sort of basis to have a communication with one another what's happening. And when we looked at these criteria and said, number one, we allow new sites of disease, we allow things to get bigger for at least a scan or two before looking to see whether they continue to get bigger or not, that essentially we have to kind of confirm whether a patient is progressing or not. As opposed to most of the criteria, we confirm whether a patient is responding. And when we look back on some of our phase 2 data with IPI, and we compared patients with this criteria who we had continued follow-up. So at week 12, when they got the first set of scans, they showed progression, but we continued to follow them with other scans, and they didn't get any treatment in between to see whether we saw this delayed phenomenon going on. And it wasn't a huge number of patients. It was probably about 25–30% of patients who had progression that we still had data on to continue to follow. Again, this is all retrospective looking at things. This is kind of us trying to mine to kind of get a sense of whether these phenomena we're seeing hold true in a larger patient group. And what we found is those patients who progressed initially and then had some sort of benefit from these new criteria were in green. Patients by standard criteria who seemed to have a response to stable disease were in this kind of orange color. And patients who had no response or benefit of their disease by either criteria were here in terms of their survival. So while patients who didn't have a response or stable disease by any criteria didn't seem to do as well, the patients who looked like they progressed but then had control of the disease later on seemed to do very similarly to those who by standard criteria had a response. So it suggests that for those patients who we see this phenomenon to, they could do almost as well as patients who have a response early on. So as many of you may know, this drug then began to be developed in the phase 3 setting. And the first trial that was done is a trial in patients who have been previously treated. So patients had to have had a prior therapy. They had to have a certain genetic makeup to the immune system because one of the control arms was this peptide vaccine, where they were trying to, remember I showed you how peptides were presented, part of the proteins presented in the groove to the T cell on the surface. So this is a peptide that actually will get presented by the dendritic cell or antigen-presenting cell to the T cell, and this is the protein that's presented is called GP100. So patients received IPI at 3 milligrams per kilogram every 3 weeks times 4 with the peptide vaccine versus IPI alone versus the vaccine alone. And this was blinded, so patients and doctors didn't know what they were getting. One of the things it did allow previously treated patients with who had a history of brain disease, which many trials prior to that did not permit. And one of, I think, the paradigm shifts recently is that 5 years ago or so, even sooner, many patients with brain metastases were not permitted on immunotherapy trials. They felt that, number one, the immune system didn't work in the brain. Number two, even if it did, it would cause inflammation, it would make things worse. But I think we've changed that paradigm. And clearly that there's evidence that for some immune therapies, that even with patients with brain disease can receive a benefit, this being one of the first examples. And these are kind of complicated curves, but what it basically showed is that for patients who got IPI, they had an improvement in survival compared to those that got the vaccine alone. And this is in terms of months. So here we're talking about 3 years out, 4 years out, patients who are still alive. Now, admittedly, while this is a home run or grand slam, because it's the first example of a drug that has improved survival, this is far from winning the World Series yet. It's spring is in the air, baseball, and we talk about that. So this is what it does is shows that not everyone has a benefit, but that about 15–20% of patients have this benefit here, so-called tail of the curve phenomenon, that lasts a long, long time. So the average patient may get a short benefit, but that a subset of patients get a very long benefit with this durable, really benefit in survival of the last months to years. Now, interestingly, there's another piece of data that we look at in oncology called progression-free survival. And what that is not looking how long someone lives, but looking at how long someone lives without disease radiographically getting worse. Okay, and it's used as sometimes to get drugs approved and such, because it's easier to collect that data than to follow someone even longer for survival, which is more expensive and just harder to do. When you look at this progression-free survival, it is significant, but it seems to be slightly dampened. Not as much as you would see with a drug that traditionally prolongs survival, such as hitting a target therapy or chemotherapy. And it may suggest just that the mechanism of action. Remember I showed you some people got worse before they got better. And so using that progression-free survival endpoint is probably not beneficial for a drug like IPI, and kind of changes the way we develop trials and looks at endpoints and how we can go to agencies to get drugs approved and what we need to do to kind of understand the mechanism of the drug and what's happening at the sites of tumor in patients. So what are the side effects? Well, there are clearly risks involved when you take the brakes off the immune system. And when you take the brakes off the immune system, the risk is that you can have the immune system cross-react to normal parts of the body. And certainly by far the most common one that it reacts to can be the skin, inflammation of the skin, and about 40% can have some sort of rash, but only a small percentage of patients have what's considered a significant rash that needs real true intervention. The second most common is inflammation of the gut or diarrhea that the patients present with. And while a significant proportion of patients can have some grade, it's really a smaller percent who gets into the point of the diarrhea and inflammation that requires, say, systemic steroids to control. And one of the interesting things that was very surprising, again, all of the preclinical models and mice and all that could never have predicted any of this. It's really having kind of the clinical investigators in the community to roll up their sleeves and really get the trials through and treat patients that allowed us to understand this. But one of the things that was kind of interesting is that even for those patients who were receiving a benefit from IPI, who unfortunately had, say, diarrhea that required steroids, that benefit against their cancer seemed to continue even though you're giving a drug like steroids that may be somewhat immunosuppressive. And that was another kind of paradigm shift that we had that took us a while to realize, but still, another pleasant surprise with regards to that. And then there's some other endocrine problems, inflammation of the thyroid, inflammation of the pituitary gland, something called hypophysitis, something that we may have learned in medical school, never think we'd ever see a case of hypophysitis. It's so rare until you give a drug like IPI where you do see patients who require some steroid replacement because of it. And then much less things like inflammation of the liver and pancreas and the eye and the kidney rarely and nerves. Overall, a lot of patients have some grade, obviously a majority of this being skin and such. Some of them having two different kinds of side effects, but still about 18–20% having where they may need some intervention like steroids going through this. The other thing to understand is that the diarrhea or other aspects can be waxing and waning. People can come in and have a low-grade diarrhea for a long time, can have a significant diarrhea that comes and goes quickly, or things that prolong, and it's really unpredictable. And it really takes kind of a communication between patient and physician to understand how to communicate about these things and how to figure out the best way to be followed. And it really takes that doctor-patient relationship that's very important. So part of the first trial was that patients who got a benefit, who had stable disease or responsiveness, was able to go on and be followed, and if their disease started to brew again, where it looked like it was getting bigger, could get another round of whatever they got previously, so-called reinduction. And this is a very complicated slide, but what it basically tells you is that each of these colors is a different round of therapy, and they either got the IPI plus the vaccine, they got IPI alone, or they got the vaccine alone. Now, obviously, most of the patients who seemed to get a benefit and then needed more were the ones that got IPI in some way. Some patients actually went through 4 rounds of treatment. And then the interesting thing here is some patients who had stable disease with the first round went on to have partial responses or complete responses with subsequent treatments. And what it kind of tells you is, number one, that the system can reset itself. And number two, even when it resets itself, it can respond to a drug like IPI again, and many patients still get a benefit from it. So the second big study was in patients who were not previously treated. So these were untreated patients with metastatic disease. And they got IPI at a somewhat higher dose, 10 milligrams per kilogram every 3 weeks for ×4, and then every 3 months as a maintenance, either with chemotherapy or chemotherapy alone with a placebo. And this was another fairly large trial. And what this showed is that if you got the IPI, there was an improvement in survival. Again, the difference for the average person was only a couple months, but this tail the curve phenomenon, where you have like 10–15% or so of patients who receive a long-term benefit compared to those that got chemo alone. Again, this going out 3, 4, 5 years. Okay, something that we really had never seen in patients before, having these benefits that are durable for years. And again, that progression-free survival issue, while still significant, seemed to be watered down. So that same issue, I think, was very similar with the second trial than it was with the first. So IPI plus chemotherapy prolonged survival compared to chemotherapy alone. The second trial to show a survival advantage, very confirmatory. And one of the interesting things regarding this trial is that there was very little colitis, very little of that inflammation of the gut that we saw with IPI by itself. Whether the chemotherapy affected that or not in some way specifically is just one of the hypotheses. But interestingly, there was increase in the liver enzymes more frequently in this trial than the other trials. And one of the things that we kind of retrospectively went back and looked at is that patients who get dacarbazine chemotherapy, DTIC, can have transient elevations in the liver function tests, in that maybe that in itself set up a patient to get more of those when you add IPI to it. It's kind of one of our thoughts, but albeit that's what the data showed. So IPI is the first drug to demonstrate prolonged survival in randomized trials, and interestingly, I think, and importantly, represents a new class of T-cell stimulants, the first in class that could be applied to many different kinds of cancers. So the next question is, how can we improve upon these results? And one of the ways that I showed you about the vaccine with the cytokine GM-CSF vaccine is trying to find additional ways to combine that. If you can prime the immune system, educate it, and then take the brakes off with IPI, maybe you can get away with even doing better. The problem with what I told you about the vaccines is that making a personalized vaccine that way is incredibly labor-intensive and really unaffordable in the current environment that we live in. So we started a trial of combining systemic GM-CSF, that is injections of GM-CSF that's been used for helping bone marrow transplants and other things. Patients get an injection daily plus IPI versus patients getting IPI alone. And this is a trial that's completed. We'll see hopefully within maybe even as soon as next month whether the addition of the GM-CSF had any benefit to patients. This is the trial design. One of the other things that has been of interest to us is that when we biopsied patients on IPI, we found that the immune system was actually attacking the blood vessels feeding the tumor deposits. Something that was really kind of surprising to us in how you could induce the immune system not to find just the tumor, but to find the blood vessels specific to the tumor while not really affecting normal blood vessels around there. It really kind of made us start to think about how the blood vessels and tumors are different, which we knew. They present different kinds of proteins, but really that the immune system could actually preferentially identify those blood vessels and kill them and cause tumor cell death too and spare the rest of the normal blood vessels. So one of the molecules that makes blood vessels, called VEGF, vascular endothelial growth factor, has been an incredibly important target for cancer in general. A drug called bevacizumab, or some may know it colloquially as Avastin, is kind of a blockbuster drug for a number of different kinds of cancers. And it's something that's been shown to be combined with chemotherapy to have effectiveness for many kinds of cancers. We also knew that if you blocked VEGF, one of those blood vessel making proteins, that you could actually help T cells cross from the blood vessel into tumors. So for those three reasons, the immune system attacking the blood vessels, the fact that VEGF can suppress the immune system in many ways, and that VEGF, if you blocked it, may help T cells get to the tumor, we were therefore interested in combining a VEGF blocker. Bevacizumab is one word, but probably know it as Avastin, plus IPI in patients with melanoma. Try to see if there's a synergy in bringing those two drugs together. So there were two cohorts that we described. We used the higher dose of IPI. We started a half dose of the bevacizumab or Avastin, and then went up to a full dose. And this is some of the scan results. So here's a patient who has a liver metastasis here, and on PET scan it lights up. 8 weeks later, the liver metastasis is still here, as seen as by the shadow, but metabolically it's not active anymore in the PET scan. So this kind of gives you another hint, though, of how we struggle with determining whether someone's benefit or not. It took another 8 weeks until this tumor began to shrink physically, until it's now 30% where it started. So even if it didn't shrink initially, we knew that something was going on by PET scan that seemed to be beneficial. So out of the first 22 patients, we have 7 patients who either had a partial response or a complete response, another 7 patients who had stable disease for 6 months or more, and 8 patients who had progressive disease from the start. We did see some autoimmune side effects, though. We saw a number of patients with high liver function tests. We saw a number of patients with some rashes, another patients who had the inflammation of the eyes that required steroids. A little bit more than you would expect by IPI alone potentially, but still very manageable. And interestingly, we didn't see any patients with any significant diarrhea or inflammation of the gut. When we looked in the laboratory, we saw that some of the immune cells were being activated in different ways than IPI by itself. When we biopsied some of the patients after treatment, we saw some of the blood vessels kind of ballooning, that with lots of T cells coming from the blood vessel into the tumor. So we really thought that this, at least on the first blush, that the adding of the bevacizumab or Avastin and blocking VEGF did kind of synergize with IPI by allowing more T cells to come out and go into the tumors and actually kill some of the tumor blood vessels themselves. So just to kind of finish off here in the whirlwind of immune therapy, which is very hard to do in a half an hour, I'll tell you, is that this is just the beginning. So we talked a bit about IPI. We talked about how to build upon IPI. We know that it improves survival, but we want to try to combine it with maybe cytokines like GM-CSF, maybe something with like Avastin. IPI, there's a trial of IPI plus the BRAF inhibitor vemurafenib that has just been recently started. So the field is really trying to move forward to try to build upon IPI as a platform. But from an immune therapy standpoint, because that's what I was kind of asked to focus on, this is just the beginning. And this very complicated slide isn't meant to confuse you more. It's meant just to kind of give you a view that CTLA-4 here, which I showed you here, is one of a family of molecules that's involved with regulating the immune system. So when the immune system decides to make an immune response against something or not, or to be told to stay back or to go move forward, there are many traffic cops involved here. And CTLA-4 is just one of them. But out of all of these, many of these are either have been being targeted now in the clinic as other ways to take the brakes off the immune system, or about to be targeted in the clinic. And the one that has gotten the farthest along so far and has gotten some press is a molecule called PD-1, which stands for programmed death. And it's something that's found in T cells. And on the other side of the equation is PD-L1, stands for ligand, which is just kind of the lock and key. One's the lock and one's the key that fits together. And PD-L1 is a molecule that is found on a lot of tumors. And one of the interesting things is we're learning more about how the cancer cell is able to evade the immune system. And one way it does that is it makes this molecule PD-L1 that kind of stiff-arm the immune system. It's a cloak. And so any T cell going around who sees PD-L1 on the surface of a cell, being a tumor cell, well then the T cell is going to go ahead and die or be put to sleep. And unfortunately, the tumor cell takes advantage of that. So what we've done is we've developed antibodies that blocks this interaction. So PD-L1 is upregulated in tumor cells. I told you it kind of does the stiff arming. It's the cloak. It's been linked to poor outcomes in a number of cancers. And its expression has been associated with less immune cells that are around the tumor if you were to biopsy a tumor. So if there's a lot of PD-L1 around, there's not much T cells around. Kind of makes sense, right? That's what, unfortunately, it was meant to do. So a couple of years ago, Mario Schnell at Yale presented for the melanoma community the first hint of some data against the PD-1 antibody in a number of cancers, with melanoma being one of the focus for this trial. This is just kind of describing the antibody in some detail. We can get into it in question and answer if you're interested. So just the first few dose levels that were tried. Again, it's a phase 1 early, first into human trial. I mean, this is incredibly exciting to be part of this. Really, while there were some side effects, most of these side effects relative to other drugs were fairly benign and manageable. I mean, there were some high-grade ones, but these were relatively easy and tolerable. What was found is that there were actually some responses, complete responses, partial responses, stable disease, in renal cell cancer, kidney cancer, melanoma, and non-small cell lung cancer. And these are small numbers, but now there's a couple hundred patients have been treated. We expect that probably at the ASCO meeting in June we'll get some updates on all these trials. But it's really, again, building upon what IPI has shown as a principle, and now this is kind of going to the next level of biology, of understanding the immune system, and immediately expanding it from melanoma to other kinds of cancers pretty easily. And this is the so-called waterfall plot. And so what this is that this tells you patients who are responding with their diseases getting negative. So these are all patients whose tumors are shrinking, and this is patients whose tumors are getting bigger, going up. We're talking about almost 2/3 of patients whose disease seems to be relatively well controlled in this phase 1 study, which is fairly remarkable right now at this early stage. So basically, this drug is easily tolerable. The adverse events, the side effects are consistent with what we've seen before, and we've seen activity in a number of cancers, and so there's certainly a lot of work to do right now. So how do I summarize kind of what we've been through? IPI is the first example of a drug that has been shown to offer survival. It tells us that we need to think about the mechanism of action of the drug to understand what's happening in patients, different than what we're traditionally been used to with target therapies or chemotherapies. And I think it's a platform to build upon for combinatorial approaches, whether it be with target therapies or anti-blood vessel drugs or other kind of drugs that we have more traditionally been used, such as cytokines like GM-CSF. excitingly, there are multiple clinical grade agents that are being developed that target the other breaks to the immune system. And with possibilities to combine those agents together or those agents with target therapies and such, really offers a tremendously bright future for the development of effective and safe therapeutics for patients with melanoma, and to build upon this for other cancers. So just in some of the work I presented, it really takes a complete team in order to do these studies, and I particularly want to thank Glenn Dranoff, my long-term mentor, George Murphy, who helped us with pathology analyses, and really the entire team here who helped with what it takes to take care of patients to do clinical trials nowadays. So I want to thank you for your time.